information with us. I apologize, I have the wrong window opened up here. So before we begin, we want to describe an echo session and what sets them apart from other trainings. In essence, echoes allows us to move information, not people. It allows you, the participant, to actively learn about a topic and become a resource for your community. Each session, there will be a formal didactic portion on a designated topic, followed by a case presentation. This is an opportunity for a participant to present a case of a patient and get feedback and resources from our content specialist, as well as other participants. It's an excellent opportunity to learn about new resources and ways to treat your patients. We encourage you to take part in the case presentation during the discussion. And also, if you are interested, please consider presenting a case in an upcoming session, and we'll provide more information to you in order to do so. Your participation is key to the success of our echoes. We aim to create an interactive community where our presenters, stakeholders, and community members all communicate and support each other during a session. We encourage you to turn on your camera if you are comfortable doing so. We appreciate when participants engage in asking questions after the didactic and provide feedback for the case. These narratives are the best way to solidify skills learned in the didactics and receive direct advice. If you'd like to present a case study in the future, please let us know. Questions are welcome and will be answered if time allows. If you have a question, please type it into the chat box and we will answer it at the end of the session. If we run out of time, we'll make every effort to provide feedback in the supplemental resources that we'll email out. Individual privacy is of utmost importance to us when sharing information during our case study discussion. Please avoid using any real names or initials that might identify someone. Also, please refrain from identifying an individual's family members, friends, or any other information. You can earn CMEs and social work credits for participating in our series. To receive credit, please fill out the evaluations that will be sent out to you after this session. And we will distribute the CMEs after our series, actually after each session. I apologize, some of our sessions we issue them out at the end, but for this one, we issue them out after each session. So just some housekeeping things. If you are new and you just registered for this series, please note that the calendar invites from the Constant Contact registration software don't reflect the actual session schedule. So we will follow up with you and send you the actual calendar invite. So please don't accept anything or download anything from those confirmation emails. So we would like to introduce our Echo Hub team. I will go ahead and get started. I'm Krista Opstedal. I am the Project Echo Coordinator at Minot State University. And we are working with the Department of Health's newborn screening program. So Amy and Joelle, would you like to introduce yourselves?
Good morning, everyone. I'm Joelle Meyer, and I'm the Newborn Screening Program Director at the Department of Health and Human Services, and we work within the Special Health Services Unit. So welcome.
And I'm Amy Burke, and I also work in the Newborn Screening Program within the Special Health Services Unit.
Thanks, ladies. Kyle, do you want to introduce yourself?
Yeah, absolutely. Hi, I'm Kyle. I'm one of the newborn research.
And Jody.
Hi, I'm Jody Patchen, and I'm the Administrative Assistant for Project Echo at Minot State.
We'd also like to give a shout out to Nancy Hostetter. She's with UND, and they are helping us with the CME coordination. So thank you for all your hard work, Nancy.
Well, thank you. If you guys have any questions about CME, just let me know. Thanks.
Okay, so we're going to go ahead and get started. I'd like to introduce our presenters, Stacy Chadwick and Pat Spear. Stacy is a registered nurse with 28 years of experience in various aspects of the nursing field. She started her career in long-term care, then moved to adult care at West River Health Services, which is a critical access hospital health system that also has 6 rural clinics in Southwest North Dakota. Being in a rural setting allowed opportunities to provide patient care in many settings, such as quality improvement, infection control, risk management, population health, and value-based care. She started with Blue Cross Blue Shield of North Dakota in August of 2021 and is the medical home quality coordinator. Our team oversees and supports the quality components of Blue Alliance and Blue Alliance Care Plus, plus value-based care programs. Along with Stacy, Pat Spear is presenting, and she is a registered nurse with over 30 years of experience in a variety of areas of nursing, which include inpatient, home health, ambulatory care nursing, and internal medicine as a clinical supervisor. And she is also certified patient-centered medical home model for all of the primary care locations within the health system. Pat's current position is the medical home manager for Blue Cross Blue Shield of North Dakota. This role is to support primary care providers in North Dakota through a value-based program called Blue Alliance. This program is designated to promote prevention of illness and chronic disease management. Pat is one of the clinical contacts for participating providers. Please help me welcome Pat and Stacy. I'll go ahead and get your. Oops.
Good afternoon. So my name is Pat Spear, as was just introduced. And so Stacy and I are going to talk a little bit today about the value of having partnerships between payers and providers and how those partnerships can really lead to increased quality outcomes for our patients and families through patient-centered medical home model. Next slide. And we have no financial disclosures to report. We can go on to the next slide. And so our objectives today are really to talk a little bit about patient-centered medical home standards and how they are foundational to improving quality of care and lowering total cost of care. We're also going to discuss how practice transformation towards the PCMH care model benefits patients and families, and explain the impact of developing those partnerships that to really improve quality specific to well child visits. Next slide. And so this is just kind of a depiction of we all are in this together. And so we can't do it alone, and working in silos, we've kind of shown does really not work. And so really coming together, payers, providers, and then the patient at the center of that care and their families, and being a part of that care really has been proving to have some incredible outcomes. And we're going to talk about that today. Next slide. So this is kind of a traditional model. And so this is kind of, our house is broken. And so we've got traditionally fragmented care. Oftentimes, traditionally, we've had patients that are coming in for episodes of care, and they might be seeing multiple providers along the way. They might have difficulty accessing appointments, and they may then lead to no follow-up, or they might have overuse of testing, or they could end up going from one provider to the other and not knowing what their treatment plan is. They may end up in the hospital or the emergency room, and they may end up at home and completely confused and not knowing what their next steps are and where they should go from there. And so this really is a day in the life of a patient. So if you think about that, this is what some of our patients might be experiencing. And so this is a real challenge for them if we consider what might be happening in the day of our patients, and how frustrating that might be. And it's also frustrating for care teams. I've worked in these settings, and I've seen it happen where patients are maybe discharged from the hospital and they come home and they don't know what their next steps are, or they have the medication list is all messed up and they don't understand what they're supposed to be taking when they get home from the hospital, and they might overdose on medications or something like that. So it's really confusing sometimes for patients. And again, this isn't every case, but it can happen. And I think we want to just look at how we can do better together. So we'll move on to the next slide. And so why patient-centered medical home? And so that's really what we want to talk about today. And so patient-centered medical home models really have been building foundations for different payment models. So most everybody's heard by now that the payment structure for everybody has really been changing, moving more away from those episodic care volume to value-based payments. And the infrastructure within the patient-centered medical home standards is really set up to do just that, and set providers up really well for being successful in these kinds of arrangements. It also builds in an integration of services beyond the four walls of a clinic. So patient-centered medical home really encourages providers and health systems to look beyond their four walls and look into the community and look at what's available in our community that might meet the needs of our population. And again, as we know, looking at those social determinants of health and tapping into all the resources that might be within your community, but maybe not within your four walls, to find out who might we want to connect with to help our patients navigate some of the difficulties that they might be facing. Many federal and state payers are incentivizing for patient-centered medical home models. We hear from different parts of the country. Medicaid has really been doing this for quite some time. In some states where Medicaid payments are really tied to having a patient-centered medical home type of a recognition. And so not everybody does that, but there is various levels of incentives that might be out there amongst different payers. And so the patient-centered medical home model really does enable a practice to implement different processes of care, looking at how you do work and implementing the patient voice into that many times, looking at what does the patient want and expect from us. And when you bring it all together, it really does improve staff satisfaction. It improves patient satisfaction. Nurses, medical assistants, CNAs, reception, everybody from the front door to the physician working to the top of their license. It was said once in a project that I was working on, you know, if it doesn't require an MD behind your name, you shouldn't be doing it. So who else on the team would be the right one to be doing that work, so that the physician or the nurses can be freed up to do what they need to do to care for that patient? Because there's so many people that can do such great work if they can all work to the top of their own scope of practice. And so moving on to the next slide. So this is where putting all that together really puts our house in order, so to speak. And so that really does bring together the patients and families at the middle and at the center of their care. They feel more involved in their care. They feel like they know what their care plan is. It is a better experience for them. Their care is coordinated. Their quality is improving. The necessary care needs are being addressed, whether it's immunizations or whether it's breast cancer screening or whatever the case would be. Things just don't fall through the cracks if you have a care team built around that physician practice and around those patients. The care is more comprehensive, and it's a team, everybody working together for the common good of the patient and family. And so they have access to that care team when needed, and oftentimes in between appointments for routine and the things that they might need. So it just is a better feel all the way around. And there's lots of studies out there that show that the patient feels more cared for, and physicians and nurses and the care teams actually are happier in these kinds of models of care. So I'm going to turn it over to Stacy, and she's going to take a deeper dive into the standards for PCMH model.
Hi, everybody. So if you can go to the next slide, please. So like Pat said, I'm going to cover the PCMH standards, and these were last updated by NCQA in 2017. There's 6 standards, and they all align with the principles of primary care, including pediatric primary care, which is the focus of this ECHO series. So the 6 standards are team-based care, knowing and managing your patients, patient-centered access and continuity, care management and support, care coordination and care transitions, and then performance improvement. And so the patient is of course, the first piece of the puzzle, and then everybody joining in, like Pat discussed with the medical neighborhood, and forming that team-based care approach. The medical home concept has been around for several decades. It was first introduced by the American Academy of Pediatrics in 1967. So it's not a new concept, and then NCQA launched the first PCMH recognition program in 2008. And you can go to the next slide. So I'm going to just go into each of the standards in a little bit more detail. The team-based care standard is providing continuity of care, communication, knowing roles and responsibilities. And like Pat discussed, working to the top of your license. So people doing the jobs that are based on what their licensure allows. Making sure everybody has established processes, that all team members know what their role is. It allows for more coordinated care and patients aren't falling through the cracks. When everybody knows what they're supposed to be doing, then nobody's wondering if somebody took care of something or didn't take care of something. Patients and their caregivers, parents, children, they know who to call when there's an issue or when they have a question. It builds that trust relationship. It could potentially, if they know who to call, you could potentially head off an ER visit or a hospital admission. So providing that well-functioning team leads to overall increased patient, provider, and team satisfaction, which then in turn can improve quality outcomes. Next slide. So the next standard is knowing and managing your patients. So this is capturing and analyzing that information about patients and panels of patients that the practice serves, and then using that information to deliver evidence-based care that supports the needs of the population, and making sure that it's appropriate culturally and linguistically. So the right care for the right person. Collecting that information, it makes it very helpful using different registries and EMR tools, such as patient panels that might be available within the EMR to identify groups of patients that could benefit from increased support, care coordination, things like that. Many EHRs now have tools embedded in them to help identify social determinants of health, gaps within the assessments within the EHR and things, to look for those insecurities such as food, housing, maybe even childcare issues to trigger and provide that increased reach out to patients and their families. Using the tools for different screenings within the EMR, identifying patients at risk for mental health and substance use disorders. Many patients go undiagnosed and untreated, but having a medical home model can play a critical role in identifying patients with these conditions. Pediatric patients might tend to get overlooked with the various screenings, but if they're used appropriately for the right ages, issues can be identified early, and then early intervention started in those adolescent and teen years. Also, having a standardized medication management process with medication reconciliation and assessment of any barriers with medication use can help and prevent adverse events with that as well. Then the next slide. The next one is patient-centered access and continuity. The PCMH model expects continuity of care so that patients and families will have access to care when they need it, and clinical advice when they need it as well. So keeping in mind the specific needs of the population. Different examples of this are listed, such as same-day appointments for urgent and routine care needs, expanding access outside of normal business hours, having a secure messaging system available. Parents of children may prefer to communicate electronically for their questions and concerns, especially as, I mean, our world is turning into more electronic, and technology is really at the forefront. So having that patient portal is key. Telemedicine, I think that really came to light during COVID, and having that option available for appointments so that access to care, there isn't a barrier as far as coming into the clinic. And then having a 24/7 nurse line is also beneficial for those questions that don't necessarily need to go to the primary care provider. I've seen, or we've seen in our interactions with different providers that some of them setting aside special evening or Saturday clinic hours specifically dedicated to well child visits to make that easier for access for parents of school-age children or working parents as well, so that they have a better opportunity to get their children in for those preventative care visits. Next slide. Care management and support is the next standard, and this is identifying patient needs at the individual and population levels. So like we talked about, social determinants of health, what's going on in the community, and this allows for effectively planning, managing, and coordinating patient care in partnership with the family and the patient. And then, of course, placing the largest emphasis on patients at highest risk. So those with mental health conditions, high cost, high utilization patients, those that are poorly controlled with or complex conditions, like I talked about, social determinants of health, and then those with referrals to specialists and things like that. Having an established care plan is very important, and sharing that care plan with the patient, the family, as well as all members of the healthcare team. Some practices have dedicated social workers or other types of support staff that are like a case manager for children with chronic conditions to be in charge of that individual's care. So having integrated behavioral health falls under this as well. So helping those children with mental health diagnoses. Integration allows for more smooth handoffs and those transitions of care between primary care and behavioral health. Next slide. We go into care coordination and care transitions. So looking at tracking of tests, referrals, and those care transitions, post-hospital discharge, post-ER visits, things like that, to achieve high quality care coordination and keep costs lower, improving patient safety, and ensuring that effective communication within the medical neighborhood. Practices need to have a system in place to track and manage those lab and imaging tests, and making sure to inform the patients of those results. This is where that secure messaging and patient portal is very critical. That can be sometimes immediate notification with those types of setup. Following up with inpatient facilities, especially with newborn hearing and blood spot screenings that fall out. Who is responsible for notifying the primary care practitioner if something is abnormal on those screenings while the infant is in the hospital? Who's responsible for the follow-up? Is the hospital setting that up? Is the primary care provider setting that up? Having those established processes really helps so that those kids don't fall through the cracks on that. Also under this is improving relationships with specialty care, making sure to close that referral loop, reducing inappropriate referrals to specialty care. So if it's not needed, coordinating that. building better connections within the community and working collaboratively with other practices, and then just supporting the patients through those care transitions. Again, having that case manager for those with chronic conditions. Next slide. The last standard is performance measurement and quality improvement. So establishing that culture of data-driven performance improvement on clinical quality, efficiency, and patient experience, engaging staff, patients, families, and caregivers in those quality improvement activities. Just ensuring that that continuous quality improvement practices are looking at their patient experience surveys, having that patient panel, patient and family advisory committees are very useful, and providing that place for the voice of the patient, really, and hearing from them, hearing about their experiences, and then making changes if needed based on perhaps negative experiences as well. So, and then sharing that information with the rest of the team also is critical. And then with that, I will turn it back to Pat, and she will dive into some well child specific information.
Yeah, so this is, we'll kind of bring everything together to a project that happened in North Dakota, and a very exciting thing that we got to be a part of a few years back. And so back in about 2015, 2016, Blue Cross started our own value-based program, which is Blue Alliance. And so we noticed or saw that well child visits within the state of North Dakota was far below the 5th percentile with NCQA benchmarks. And so it became a really important thing for our providers on our clinical quality committee and our program to kind of start with, let's look at well child infant to 15 months. And we started with that measure, and then ages 3 to 6 at that time were part of the HEDIS measure sets. And so that's how we started out with looking at that. Within our Blue Alliance program, there are incentives for quality improvement, but also we've seen some amazing innovation around these two measures, and really, quality innovation around community partnerships and, backpacks for kids, and just a lot of different initiatives in different communities in North Dakota. We started seeing right away within the program, and a lot of energy around improving getting kids in for these wellness visits. So that was exciting just to start the program. And so next slide. Then in February of 2017, we started a statewide initiative, and we decided, we heard from our provider partners that we wanted to go outside of our own program and look at who else in our state could we partner with. And so we had a statewide collaborative, which was to really help families and patients and communities at large understand the benefits of a well child visit and the importance of these preventative health beginning early in life. So we partnered with many North Dakota State Health Department, Oral Health Department, Public Health. There was several different clinic organizations that were a part of our Blue Alliance program at the time as well. We all came together under one focus, and that was really to look at what do we need to do to improve well child visits in our state. And so the group came up with and did a survey and found out some of the things that might be the most important. And we looked at communication and marketing being a focal point, public health, partnerships, and then education, just education on what was a well child visit for both internal and external partners. And so we set a goal. We're 5% over the next year's time to improve our quality by. And I will tell you, the group was quite nervous even to set that as a goal because it just seemed like it might be hard to do. So that was kind of how we started that. We developed marketing tools, and we developed a general handout that provider groups could take back to their own organization. And it was generic enough so that they could make it their own. or they could use that, you know, without a whole lot of branding on it so that it could be used according to whatever standards that they had to follow. We met with public health agencies throughout that year. We looked at how can we better partner together? How can we work together to improve that? And lots of our clinic partners were already within their own local community partnering with public health. And so there was a lot of best practice sharing that came out of some of that. Did many poster presentations, went wherever we could go. Some of our partners even were at the legislative day, so that just to get the word out about why this was important. Presented at the wellness summit that Blue Cross had, and just really did a number of things. Lots of our clinics took education back internally and did education with their nurses, their providers, and many different areas of doing community-wide education to just share why this was important. And then to go on to the next slide, it kind of shows how we ended up in this. So after about a year's time, we got some new quality data, and we were able to not only achieve our 5% goal, but we went well beyond it. And so we were pretty proud of our results. And so we far exceeded our goals for both well child infant to 15 months and 3 to 6 years. And so we still have work to do in this measure though. So even at the end of this initiative, we were still not to the 50th percentile for NCQA. And so we still remain working on this. And so our provider groups are still working to improve this quality measure. But we do really appreciate the collaborative effort and the partnerships that we gained through this work. And I think a lot of those partnerships are ongoing. So next slide. So this is just for our Blue Alliance program. We've continued to see improvement. I know we know that many of our provider groups are doing some really innovative things, as Stacy had kind of alluded to. And so over the time of our Blue Alliance program, and that's been in place now for 6 years, we have seen a 25% increase over time for the infant to 15 months measure, and 24% over time for the 3 to 6 years. And so we're pretty proud of that. And we are proud of all the provider partners in our state that have been working hard at this over the last 6 years and really coming up with some unique and innovative ways to really improve the wellness of our kids. And so next slide. So along the way, we also have had some challenges, as we all know. We've had a pandemic, and still have pandemic impact. And so we've heard a lot of really interesting things that people have had to do differently. We've all had to pivot really quickly. But one thing that we saw was that those clinics that we talk to, Stacy and I do a lot of talking with our providers and finding out what some of their barriers are, what some of their challenges are, and what can we do as on our team to try to help support them too. And so we've learned that those clinics that were either designated as a patient-centered medical home or had built the infrastructure. Not all the clinics in our program have a designation for PCMH or recognition, but they have built a lot of the infrastructure. As Stacy shared all those standards, a lot of clinics are doing that work. Those clinics were able to pivot relatively quickly when it came to the national worldwide crisis that we had, and they were able to make those shifts really quickly to move to telehealth or to set up different clinic sites or clinic times. Some people designated only mornings for well child visits or afternoons for sick kids. I did a lot of different unique things that were pretty innovative, I think, and just really had to adapt so quickly. And I think that really helped set them up well because they've had developed their teams, they had developed their processes, and they were able to move quickly. And so again, ensuring safety for their children, families, that was a big, we heard that a lot. That was a huge concern, obviously for everyone. So we did see a little bit of our quality scores around well child drop during that time, understandably, but they are already rebounding. So I think that is a testament to the clinics, everybody that's been working so hard at that and being able to make that shift. Again, having those foundational elements in place. And again, it just kind of demonstrates the collaboration, the partnerships, the looking outside the four walls and having all the infrastructure in place of a medical home and a medical neighborhood really has been able to help our state rebound in some ways in this measure. And so we're pretty proud of that. So the next slide, just kind of, again, kind of in summary of what we've all been talking about, PCMH models really do engage the team and the patients to improve their health. And so building those care plans out with the patient in mind and with their unique needs in mind really does put that infrastructure in place for overall health and wellness. And so again, partnerships with payers, partnerships with the community, and partnerships with everyone at large really do provide that necessarily practice transformation that build the good foundation to improve access and care coordination. You know, I've heard it said that you know, that primary care has been in a crisis for some time because there's so much work that needs to be done. And so building those partnerships between payers, providers are really necessary to build the sustainability for the future of our healthcare. And so payment models are shifting and changing, and we need to move in that direction. And so we want to be, we're all in healthcare. And so we all feel like that those partnerships really do improve quality outcomes, as we've seen in our program and what we've seen in our state. We do see that that does really build a good foundation for sustainability for our patients. Your patients are members, as we say, always in our world. And so we appreciate the opportunity that we have to work so closely with many providers in our state. And so I think next slide, if there's any questions for us.